Good day and welcome to today's presentation. Please note this webinar is being recorded. All participants are in a listen-only mode. If you would like to ask a question, please enter it into the Q&A panel located at the bottom of your screen. It is now my pleasure to turn the call over to Lisa Sullivan. Please go ahead.
Thank you very much. Next slide, please. Good afternoon. My name is Lisa Sullivan, and I am the Acting Director of the Division of Community and Population Health here at the Centers for Medicare and Medicaid Services. We are so pleased to have you joining us today for the Comprehensive National Nursing Home Training. This training is being offered 5 times to accommodate our nursing home audience today, and today is the third of 5 sessions. A couple reminders before we get started. The slides and the recording from today's sessions will be posted to the QIO program website. We will have at the end an open discussion period, but please keep in mind that we will get to as many questions and comments as time permits, and if there are any unanswered questions, we will have to address those afterwards. Along with our speakers today, we also have one of our CDC colleagues on the line to answer questions, and that would be Namali Stone. In addition, we have Bonnie Reed, Kathleen Lawrence, and Sheila Huns here from the Division of Nursing Homes, also at CMS. And we're grateful for them to help us with all the question and answers that we will get. Please note that we will also have a post-event survey that we would ask you to fill out. It only takes a few minutes and really helps us plan and improve our training going forward. So we do ask you to fill that out for us. Next slide, please. And I'd like to go ahead and introduce our speakers for today. We have 4 impressive speakers for you: Eli DeLille, Deb Smith, Dr. Kimberly Rask, and Susan Purcell. Our first speaker will be Eli DeLille from HSAG. Mr. DeLille serves as an infection preventionist with more than 16 years of experience in the healthcare industry with expertise in quality improvement, analysis, and implementation of performance improvement, patient safety initiatives, and direct patient care. Mr. DeLille earned a master's degree in nursing from Marshall University. He is certified in infection control and is a fellow with the Association of Professionals in Infection Control and Epidemiology. I would now like to turn over the call to Eli DeLille. Eli, the virtual floor is yours.
Thank you, Lisa. I appreciate the introduction and the opportunity to be here. Next slide. Today I'm going to talk about establishing an infection prevention program as well as conducting ongoing infection surveillance. Next slide. Some key things that I want to focus on is developing a system for preventing, identifying, reporting, investigating, and controlling infection and communicable diseases for all residents, staff members, and visitors. And this seemingly simple sentence doesn't really respect the fact that in the U.S. right now, we've exceeded 3 million positive coronavirus cases and have 135 deaths as of this morning. We want to make sure that we're establishing goals and priorities for your program to help address the illnesses and loss of life that we're experiencing. We want to make sure that we plan and implement strategies to achieve goals, monitor compliance, and respond to identified issues. Next slide. I can't really talk about infection prevention without really focusing on the importance of training. And right now we need to make sure that we're dedicating the time and resources to our designated infection preventionists to complete some form of training. Personally, I think that the CDC has the best offering available. It's a self-paced training. It's 19 individual modules, and it's designed for working staff members to complete as they have time. And some of the modules are as short as 15 minutes, so that even the busiest infection preventionists can complete them. They also offer continuing education credits, and this will help kind of set the stage on your infection preventionists knowing what to do as they get acclimated to that role. Next slide, please. What we have noticed is from feedback in our partners across Arizona and California is as good as the CDC training is, it doesn't necessarily prepare the staff member to work within the state or the particular facility. So we're fortunate to have 50 plus years of infection prevention experience at our company. And we sat down as a group and created a tool to help orient that brand new infection preventionist. And the example I would use is the reality that many of you are facing is I work with a nursing home that their DSD quit. They hired another infection preventionist and their ADON quit. And that DSD person is splitting so many different roles, it's hard for them to prioritize. So this helps to standardize what they're learning to ensure some consistency, especially if you have more than one person trying to fill that role. You want to always designate a lead infection preventionist, but the reality is it may be split between those 3 staff members. This helps to define a criteria so that if you do have surveyor questions on how your particular staff member was acclimated to their role, you can show them this form to show that you had that consistency and that foresight to orient them to their position. Next slide, please. Once you've laid the groundwork and you have that basic knowledge, you've been oriented to your role, it's very important for your infection preventionist to get an idea if there's a disconnect between their policies and their processes. And once again, the CDC has created a great tool and an ICAR assessment for COVID-19. This was initially developed for public health officials to go on site or do virtually and help nursing homes identify their opportunities. And what we've discovered, as well as QIOs and other organizations across the country, is this is the perfect self-assessment for a facility, a new IP, an experienced IP to go out and see if they have opportunities. It breaks it down into 5 key areas that we're going to cover more in more detail, throughout the rest of this presentation. Next slide, please. Once you've gone out and done an assessment, you have a better understanding of where your opportunities lie. It's very important to put that down in a plan. You want to document this for your staff so you can share your findings and that you can spread the ownership between your managers, your staff, and your providers. At HSAG, we created this plan for COVID-19 pandemic, but we also have others available that go from antibiotic stewardship all the way to vaccination, which is going to be especially important as we begin heading into the flu season. You want to have a timeline. So if you did the assessment today, we want to make sure that you're actioning those identified areas of opportunity quickly, because right now, as I mentioned before, there's just an incredible toll being taken on our elderly and our infirm right now. And then finally, you want to make sure that you're watching your outcome information. Facilities are mandated to report their their COVID-19 information to NHSN. Your quality improvement organization, CMS, your state health departments, we're all watching that information very closely to see where we need to target outreach. And data quality is something that we've all identified as an opportunity. So if you're struggling with this as a nursing home or as an administrator, reach out to your quality improvement organization. We're waiting in the wings to help you, and many of us have extensive knowledge in NHSN reporting. We also want to look at process measures. So within the states we operate, California and Arizona, we found that auditing hand hygiene compliance, isolation compliance, source control, and environmental cleaning offers the most benefit to our partners because it dramatically impacts the number of COVID positives they're seeing and gets staff really to be on the same page. Unfortunately, going out and auditing and not documenting who you talk to, what you talk to them about, can't really show your improvement over time. Next slide, please. Next slide. You can't really create an infection prevention plan in isolation or in a silo. And as a new IP, I know that I used to think that I could be everywhere for everybody, cover every shift, but there's only so much one person can do. And the more people that you engage and you get their feedback on your plan, you're going to have advocates and champions out there to help you push your platform, but also make sure that their needs are met as well. And I know personally, I think that I covered every single base, and I'm always shocked when I don't bring the right person in or don't get feedback from the team, just how much value and insight they can offer. You want to make sure that you're educating your staff when you have a plan like this, because often we tell them what to do, but we don't always tell them the why behind it. And that's crucial right now to ensure everyone's on the same page. We want to empower staff to speak up if they identify a concern. We're all living in a very dynamic, ever-changing environment. It's scary for nursing staff, for physicians, for patients, and if they feel comfortable enough to talk to you about when they have a concern, that's one of the most important things that an infection preventionist can do, is foster those kind of relationships and feedback. As I mentioned before, you want your staff and providers on your team as well as your residents, because they're going to really help to make sure that you're successful. And then you want to modify your plan if necessary. We are working with many facilities across California and Arizona, and most of the facilities, there's been a change since we started their action plans that we've had to really go back to square one and say, all right, this is what we thought was causing the issue, but now that we have more information or we're doing these assessments, maybe we need to put additional focus here. Next slide, please. CMS asked that anything we brought today that nursing homes could immediately take out and begin using. So on the QIO website is all the tools and resources, as well as many more that we've developed for our partners across the nation. And I encourage you all to check that out. Next slide, please. Next slide. Unfortunately, IPRO couldn't be on the call today, so I've been asked to do their presentation around strategies for COVID-19 surveillance, as well as early detection. Next slide. And their approach really covers the CDC's 3 key steps, and that's keeping COVID out. The easiest way to control an infection is prevent it from ever happening. We want to detect cases quickly, and there's a test-based strategy as well as a symptom-based strategy. And then ultimately our goal with all the strategies I'm going to talk about today, as well as my colleagues on the line, is to stop the transmission of COVID. Next slide. IPRO focused a lot on feedback from their partners, which we thought would be extremely valuable to you on the line. And this is stuff that we've seen mirrored in each state that we operate across the nation. And it's extremely important in order to keep COVID out that we're managing staff at the door. We want to make sure that we're doing wellness checks on all individuals entering. And something that I heard back from nursing homes just this week was ensure that you're asking the questions about the symptoms, because if you just say, are you having any COVID-19 symptoms, your staff may not be aware that includes loss of smell, taste, respiratory symptoms, in some instances GI symptoms. So we want to make sure that we're exploring that and we're educating our staff so they know what to look for and what to tell you about. For staff members that are working additional shifts, 6 hours, 12 hours, we've heard of some working 16 hours, you want to make sure that you're touching base with them mid-shift because, COVID-19 is rapid. Depending on the individual being infected, it can progress very quickly. We want to make sure that we're also self-assessing at the end of the shift. Unfortunately, in California, we've had several instances where there's been evacuations just related to staffing shortages. So if you can cover a person and at the end of the shift, it just gives you more time to get those resources in place. And then finally, remember that well-trained non-direct staff are still available to help. We just need to make sure that we're training them appropriately if we're asking them to operate outside of their normal scope of services or duties. And then communication is extremely important. And as you're doing this check-in, it's a great opportunity as people are coming in the door to give them an update since what happened the day before, maybe new expectations, new guidelines, new information that you have. And another thing that we've heard is the importance of social distancing in the break room, within the facility, but then also as you're doing these screenings, as your staff members are coming in, you might want to stagger your start times just to make sure that everybody isn't slowed down for shift change, but also that we're not having everyone congregate together. Next slide, please. From an operational level, as a facility administrator, as a director of nursing, we understand that there's staffing crunches out there, but feedback that we've received from our local health departments is, we have to make sure we're not pressuring staff to work when they're ill. We have to prioritize safety and wellness of the staff as well as the residents and follow the recommendations for them to be potentially excluded from work until they're asymptomatic according to your local guidelines. I mentioned the 12-hour shifts before. That's a great way to find additional staff by eliminating that third shift. You also have less exposure in transition. If you're unfortunately needing to staff with agency staff emergently, this is where you need to know where they've been working at. We had one instance where there was a nurse working at 3 different nursing homes. They were trying to work 2 different places in the course of a day. One was in the midst of a COVID outbreak, and you had another that was COVID-free. So they had to take steps in order to make sure that staff member could safely work between those 2 different organizations. And then, of course, we want to make sure that we're preparing for staffing shortages, which is a reality that many of you are facing right now. And one of the kind of awesome things we've heard about is the number of volunteers coming out, retired nurses, physicians, infection preventionists that are waiting also in the wings to help our at-risk or in trouble nursing homes. So next slide, please. As we look at screening and keeping COVID out, communication is an extremely important facet of what we're all doing. As I mentioned before, residents are nervous. We have scared staff members, families, and the more that we leverage technology to let everyone know what the expectations are, the why behind the what we're asking them to do, I believe that we're going to ensure our success in keeping COVID out. Another concern that we've seen identified across really our states as well as what ICAR is seeing in their states is vendors still wanting to come into your facility. These are your people bringing food trucks, materials management, and we need to make sure that we have special protocols in place that we're not unnecessarily exposing our residents to someone that we could keep outside of the facility and minimize that exposure. And then finally, before I mention the concern about bringing people back to work too quickly, we also have to make sure that we can bring them back when they're ready. So having clear guidance from your local health department of when you can safely bring back a staff member is incredibly important as you look at keeping COVID out, but also taking safe care of your residents within your nursing home. Next slide, please. Next slide. Oh, I'm sorry. I had you go twice there. Can we go back one? There we go. So testing. This is something that I know that many facilities, this is a challenge depending on your state recommendations. So you want to make sure that you coordinate that with your local health department, but in tandem with this, we need to make sure that we're using symptom-based screenings as well in order to detect those cases quickly in residents. And that includes daily rounds. Many of our nursing homes have said that they're going from, daily vital signs to they're actually doing it twice per shift just because it can be so subtle. They have more frequent team meetings throughout the day just because it changes so quickly and one of these cases can evolve, and those subtle signs and symptoms in our nursing home population. And some mid-shift huddles is also an excellent time for your infection preventionists to go out and start auditing to see that people are wearing their personal protective equipment, they're doing the source control, that they're washing their hands appropriately, because that's really what's going to help to protect your residents and your staff. And then back to basics and good assessment skills. I've been a nurse now for close to 20 years, and I think that we can't really reinforce enough the importance of getting out there, talking to your residents, and then if you do have a concern, you want to escalate it immediately. The nurses have a relationship with their residents like I don't think anyone else has. They're almost like family. And if you notice that Mrs. Smith is not herself, that's the time to bring that concern to your infection preventionist, your ADON, and your DON. Next slide, please. And then altogether, these things are going to stop transmission. We want to make sure when we're washing our hands that we include the resident and make sure that they're washing their hands. If you're moving things from one room to another, we need to make sure that it's being cleaned with an EPA registered disinfectant. And if you are concerned that your product may not be appropriate, there's a great website that has on the EPA website that has every cleaning product that's approved for COVID-19 in this instance. We want to make sure that if we can engage our residents in protecting themselves and others, that we do that safely. And we also know that depression right now is something that is very concerning for many of our residents. So as much as possible as we explain things to our staff members and we include the residents, we can let them know that they're a hero in their care just as much as their nurses or providers or there's nursing aid staff that are helping to care for them. Next slide, please. IPRO has some great resources that they referenced for this presentation. Next slide. And I want to thank Marguerite and David for the opportunity to present their information today. I'm going to turn it back to Lisa for the next presenter.
Thanks so much, Eli. We appreciate your presentation. It is now my pleasure to introduce Deb Smith from Health Quality Innovators. Ms. Smith has more than 20 years of experience as an infection preventionist, registered nurse, and ASCP, registered microbiology technician. Ms. Smith is a member of the Virginia chapter of APIC. She also holds a certification in infection control and a certified professional in healthcare quality. Deb, the floor is yours.
Thank you, Lisa. Next slide, please. Good afternoon, everyone, and thank you to everyone on the call today for taking the time to share this time with us. My topic for today's training is cohorting as a core intervention of an infection prevention program, and it's currently being utilized during the COVID-19 pandemic. Next slide, please. The goal of cohorting or isolation is to prevent the transmission of microorganisms from infected, colonized, and/or asymptomatic residents to other residents, staff, or visitors who may in turn transmit that to others or become infected or colonized themselves. Residents infected or colonized with the same infectious agent can be cohorted together to prevent spreading that infection to other non-infected residents. Staff are also included in cohorting during outbreak situations like the COVID-19 pandemic to a specific cohort of infected residents, which will further limit the risk of spreading infection in your facility. Next slide, please. To contain disease during the COVID-19 pandemic, the CDC outlines a plan for nursing homes to create a COVID care unit in their facility that can be dedicated to care for residents with confirmed COVID-19. This COVID care unit should be physically separated from the rest of the facility and be in place before the first suspected or confirmed COVID cases hit your facility. The COVID care unit can be a dedicated floor, unit, or wing in the facility, or a group of wings at the end of the unit, a group of rooms at the end of the unit separated by a barrier that will be used to cohort residents with COVID-19. Nursing staff should be dedicated to work on the COVID care unit when it is in use. If ancillary staff cannot be dedicated to the COVID care unit, they should be restricted from entering the unit. Next slide, please. There should be posted signage at the entrance of the COVID care unit instructing all who enter the unit to wear eye protection and an N95 or higher level respirator at all times while on the unit. Following the CDC's PPE optimization strategy, a face mask can be used when respirators are unavailable. Cloth face coverings are not considered PPE and should not be worn when PPE is indicated for staff. Gowns and gloves should be added when entering resident rooms to perform resident care. Provide infection prevention training that includes the use of and steps to properly put on and remove recommended personal protective equipment. Resident care equipment should be assigned and dedicated to the COVID care unit. Cleaning and disinfection of shared equipment should be performed between resident care, and that equipment should not leave the COVID care unit. Next slide, please. Can you hear me now?
Yes.
Okay, I think I lost my phone for a minute. Assess your on-site and remote staffing capabilities to assure that you have adequate clinical and non-clinical staff with the required training skills and competencies in place for staffing the COVID care unit. These assigned and cohorted staff should not work across other units, floors, or facilities. If your facility does not have enough ancillary staff to dedicate to the COVID care unit, nursing staff may need to perform housekeeping and/or dietary tasks, so they'll need extra education in these areas. Whenever possible, it's recommended that nursing homes integrate consistent assignment of staff to specific residents, with the goal being to decrease the number of staff and resident interactions. Staff access between the COVID unit and the rest of the facility should be limited as much as possible. This can be accomplished by providing a separate entrance and dedicated break areas and supply rooms for the COVID care cohorted staff. Next slide, please. Next slide, please. Keeping the resident and the family informed of the cohorting process is the first step in managing a resident with COVID-19 symptoms. Residents in the facility who develop symptoms consistent with COVID-19 should be prioritized for testing and moved to a single room pending results of that testing. They should not be placed in a room with a new admission, nor should they be moved to the COVID care unit until they are confirmed to have COVID-19 by testing. Roommates of residents with COVID-19 may be exposed and should be considered infectious and moved to a single room or observation area. You can cohort potentially exposed residents in an observation area only if single rooms are not available. Residents with known or suspected COVID-19 should be cared for using all recommended PPE, which includes the use of an N95 or higher level respirator, eye protection, gloves, and gown. Next slide, please. If your facility is receiving new admissions or readmissions who have been confirmed to have COVID-19, you'll need to carefully assess each resident for placement in your facility. If criteria for discontinuation of transmission precautions has not been met, they would be admitted to the COVID care unit. If they have met the criteria for discontinuation of precautions, they would be admitted to a regular unit. When admitting residents with unknown COVID-19 status, they would not be cohorted on the COVID care unit, but would be placed in a single room or in a separate observation area, so the resident can be monitored for evidence of COVID-19. Staff should wear all recommended COVID-19 PPE when caring for these residents. Residents can be transferred out of the observation area to the main facility if they remain afebrile and without symptoms for 14 days after their admission. Next slide, please. You would want to continue transmission precautions and cohorting for all symptomatic and asymptomatic COVID-19 positive residents until criteria for discontinuation is met. The criteria on this slide are the CDC recommended strategies for discontinuation of precautions for symptomatic and asymptomatic residents. It's important to remember that if your state or local regulations are stricter and include a longer duration, you must follow those stricter regulations. If a symptomatic resident declines or is unable to be tested, you would continue transmission-based precautions until symptom-based criteria are met. Next slide, please. Finally, contaminated healthcare facility surfaces play an important role in the transmission of microorganisms, including COVID-19. Therefore, appropriate cleaning and disinfection of surfaces and equipment with residents and staff touch is necessary to reduce exposure and minimize the risk of cross-infection from one person or object to another. Environmental cleaning during COVID-19, and especially on the COVID care unit, should be enhanced and include at the minimum daily cleaning of all high-touch surfaces more frequently. And as was mentioned before, refer to that list of disinfectants to make sure that your facility is using the right product the correct way. Next slide, please. So in closing today, I'd also like to mention that each of your facilities are unique and that you may need to adapt these recommendations to your facility. These adaptations will rely on your access to PPE, available space, and the number of COVID-positive residents you currently have. You can always reach out to your QIO in your state or the local or state health department for assistance with any unique situation you encounter. So thank you for your time today. My contact information is on this slide, and I'm going to turn the program back to Lisa.
Thanks so much, Deb. Next slide, please. And one more. Thank you. I would like to now introduce our next speaker, Dr. Kimberly Rask, Chief Data Officer from Alliant Quality. Dr. Rask has provided clinical and analytic direction for economic evaluations, patient safety initiatives, and quality data reporting. A primary care physician and health economist, Dr. Rask also holds academic appointments with her research focusing on quality improvement and outcomes measurement with particular attention to rural and underserved populations. Dr. Rask, you're welcome to begin.
Thank you, Lisa. Next slide. Today we're going to cover three important aspects of clinical care for your COVID-positive residents. Number one, residents with COVID can have very different experiences with the disease. Second, the importance of having care in place that align with residents' goals and preferences. And third, the need to work with your medical directors to make sure that any necessary medications are available. As you know, COVID-19 is a new infection to us, and we're continuing to learn more as time goes on. We believe that most residents will develop symptoms within 2 to 14 days after being exposed to the virus. What is changing is that we early on focused more on the respiratory symptoms from COVID, fever, chills, cough, difficulty breathing, sore throat, runny nose. And over time, we're recognizing that the symptoms can be much less specific. Residents may have only headaches or feeling tired, muscle aches, or loss of taste or smell. Whereas we used to think of COVID as a respiratory disease, we're now thinking of it as a blood vessel disease. And that means that COVID-related symptoms are actually much broader than what we first thought and may not be very specific at all. If we then talk about the clinical course, the way that any resident will experience the disease, we see large differences. Some of your residents will have no symptoms at all. Some will have only minor symptoms. And some will have minor symptoms for 1 to 2 weeks and then become critically ill very suddenly. And that's why the Centers for Disease Control recommends more frequent monitoring of patients and residents with COVID, even if they have no symptoms or very mild symptoms. And that's also why the earlier speaker alluded to the fact that paying attention to subtle symptoms is important. Next slide. The other thing that we're learning over time is that many residents will not have any of the classic COVID symptoms. Instead, it's very common to see residents that have only subtle, nonspecific symptoms like feeling tired, changes in their mental status and their alertness, and slowly eating or drinking less over maybe several weeks. It might be a very slow downhill course. And these changes are so subtle that it's important that staff be very familiar with the residents that they care for. However, we know in these chaotic times with staff changes and resident cohorting, there may be many different staff members caring for any individual resident. And that's why it's crucial that staff have good communication strategies to make sure that any subtle changes in resident well-being can be identified and shared with other staff. We're also finding that COVID is associated with blood clots and strokes. This means that some residents may develop altered mental status as their main COVID symptom. Next slide. Now we move to our second point, making sure that appropriate care plans are in place that will respect resident goals and preferences. Advanced care planning is important for all residents, but it's particularly important in the era of COVID. As we noted earlier, some residents with COVID will have minor symptoms for several days or weeks and then suddenly become acutely ill. It's really important to have conversations about care preferences and to document those preferences long before a resident becomes sick and decisions have to be made quickly when they're critically ill. The main question often is whether or not the resident wants to be transferred to the hospital. As you know, at this time, we do not have an effective treatment for mild or moderate COVID. For those with severe COVID, ventilator support is available in a hospital. But the experience from this spring shows a very high mortality rate for older persons put on ventilators. The mortality rate was 80% for people over the age of 80, and the mortality rate was 75% for those younger than 80 years, but with underlying medical conditions, which represent many of the residents in your facilities. Residents and their families need to be aware of this as they do advanced care planning. Doing that planning can ensure that the residents' care preferences can be honored if a health crisis develops. Next slide. Finally, it's important to work with your medical directors to make sure that all necessary medications will be available. Consider having standing orders for Tylenol, supplemental oxygen, and discontinue any non-essential medications. Be sure that staff is trained as to proper resident positioning in order to improve breathing, what we call proning. Change nebulizers to meter dose inhalers if possible to decrease the risk of COVID transmission from infected residents to staff. Be sure that concentrated opioids are available in case it is needed for severe shortness of breath symptoms. If a resident is in distress, you do not want them to have to wait several hours until a medication can be made available from the pharmacy. And finally, I want to point you to the CDC resource at this link. It's a comprehensive source of information about how to evaluate and manage residents with symptoms of COVID-19, and the information is updated frequently as we continue to learn more about this disease. Thank you for your attention, and I will turn it back over to Lisa.
Thank you, Dr. Rask. Next slide, please. It is now my pleasure to introduce our final presenter today, Susan Purcell from TMF Quality Innovation Network. Ms. Purcell has been a registered nurse for 34 years, working in critical care, home health, hospice, and nursing management. Ms. Purcell has been with the QIO for over 16 years, leading quality improvement projects in case review, nursing homes, hospitals, and outpatient settings. Susan, the floor is yours.
Hello, everyone, and thank you, Lisa. And also thank you to Telligent, the QIO, who originally authored this PPE presentation. Next slide. The objective of the PPE presentation is to provide you with why and how to use PPE and give you links to resources that could be helpful. You will see that I've included numerous links throughout the slides for more in-depth information, and there's information in the chat about attaining the slides. Next slide. PPE is specialized clothing or equipment worn by an employee for protection against infectious materials. Next slide, please. We use PPE to protect ourselves, our residents, and others in the process of performing care, including protection from dangerous or infectious substances. Next slide. Listed here are types of PPE commonly used by healthcare providers to protect themselves, residents, and others when performing care. Gloves are the most common type of PPE that is used in healthcare settings. All of these serve to help keep us safe. Next slide. Based upon the CDC guidelines, PPE is to be used every day by all healthcare personnel to protect themselves, residents, and others when providing care. This also includes activities personnel, environmental services, dietary, administrative staff, hospice staff, repairmen, etc. There are instances where residents must wear PPE for protection, including attending doctor's appointments. More detailed information is available at the CDC link provided here under the tab Infection Control Guidance. Next slide. PPE must be donned correctly before entering the resident area and must remain in place and be worn correctly for the duration of work in the potentially contaminated areas. PPE should not be adjusted, such as retying of gowns or adjusting the respirator or face mask during resident care, and must be slowly and deliberately in a sequence that must be removed slowly and deliberately in a sequence that prevents self-contamination. Have a PPE buddy system in case assistance is needed. A step-by-step process should be developed and used during training and during resident care. Next slide. For more information on the proper use of PPE, I highly recommend this CDC link. There are posters in both English and Spanish that can be used for staff education, as well as videos for educational purposes. I'll go over some of the guidance now. Next slide. Standard precautions are used for all resident care. Transmission-based precautions are used when caring for those with known or suspected COVID-19 infections. Proper donning, doffing, and use is necessary to prevent self- and cross-contamination. So I'll go over those in a little more detail. Next slide. More than one donning method may be acceptable. Training and practice using your facility's procedure is critical. This is one example of proper donning. Identify and gather the proper PPE to don. Ensure the choice of gown size is correct. Perform hand hygiene and put on the isolation gown. Tie all the ties on the gown. Again, assistance may be needed by your PPE buddy. Put on your N95 filtering face piece respirator or use a face mask if a respirator is not available. If the respirator has a nose piece, it should be fitted to the nose with both hands, not bent or tilted. Do not pinch the nose piece with one hand. Respirator or face mask should be extended under the chin. Both your mouth and nose should be protected. Do not wear a respirator or face mask under your chin or store in your pocket between residents. Put on your face shield or goggles. When wearing a respirator, select the proper eye protection to ensure that the respirator does not interfere with the correct positioning of the eye protection and that the eye protection does not affect the fit or seal of the respirator. Face shields provide full face coverage. Goggles also provide excellent protection for the eyes, but fogging is common. Next, put on gloves. Gloves should cover the cuff or wrist of the gown. Now you're ready to enter the resident area to provide care. Be aware of your surroundings and what you're touching. Next slide. This picture from CDC shows fully and appropriately donned PPE. Next slide. Removing PPE, also known as doffing, is an equally important practice to prevent self or cross-contamination. Start with removing gloves. Ensure glove removal does not cause additional contamination of the hands. Remove the gown, untie the ties or unsnap buttons. Some gown ties can be broken rather than untied, but do this in a gentle manner, avoiding a forceful movement. Reach up to the shoulders and carefully pull the gown down and away from the body. Rolling the gown down is an acceptable approach. Dispose in an appropriate receptacle. Exit the room or area and perform hand hygiene. Carefully wash all hand surfaces for 20 seconds and don't forget the thumbs. Carefully remove the face shield and goggles by grabbing the strap and pulling upwards and away from the head. Do not touch the front of the face shield or goggles. Remove and discard the respirator or face mask and do not touch the front of the respirator or face mask. Perform hand hygiene after removing the respirator or face mask and before putting it on again if your workplace is practicing reuse. Facilities implementing reuse or extended use of PPE will need to adjust their donning and doffing procedures to accommodate those practices. Again, the CDC link at the bottom of the slide has more information. Next slide, please. Again, here's an infographic from CDC with the information regarding removal or doffing of PPE. Next slide. Some tips for face masks. When you put on a face mask, perform hand hygiene and put the face mask on where it covers your mouth and nose fully. When wearing a face mask, don't wear it under your nose or mouth. Don't cross the straps or allow them to hang down. Don't touch or adjust your face mask without performing hand hygiene before and after. Don't wear your face mask on the top of your head, around your neck, or threaded through your arm. And when you remove your face mask, clean your hands and remove by touching only the straps or ties, then perform hand hygiene again. Next slide. Again, a CDC infographic here for you on these face mask recommendations. Next slide. Because there are often questions regarding the optimization of PPE when there are supply shortages, and due to our limited time constraints here, I've added some additional resources here from the CDC. Next slide, please. And Lisa, I'll turn it back over to you.
Thank you so much, Susan. Appreciate that. Now we're going to roll into the open discussion and Q&A session of today's presentation. As a reminder, to submit a question, please go to the bottom of your screen, click on the Q&A tab, and type in your question. Please note that we will get to as many questions as we can in the remaining time allotted, but if we don't get to your question, we will answer any remaining questions after the event and post those to our QIOprogram.org website. As a reminder, along with the speakers today, we have Namali Stone from the CDC and representatives from the Division of Nursing Homes available to assist questions as well. And also, just to remind you real quick, there will be a post-event survey. The link to that is going to be in the Q&A box as we do this open discussion, and will also be available immediately after the conclusion of today's training. So let me go ahead and go to the first question. And it's actually a two-part question, and that is, when can nursing homes open up to family visitations again, and what guidelines do we use to consider opening up to visitation? Can one of our panelists answer that?
I would just say that CMS has issued guidance on making sure states have a plan to safely reopen nursing homes, and I can post that in the chat, but it has to do with watching COVID-19 cases in the local community, COVID cases in the nursing home, making sure that there's adequate staffing, baseline testing of all residents, weekly testing of staff, social distancing and universal source control, access to adequate personal protective equipment, and local hospital capacity. So there's very clear guidance from CMS, but then of course it has to be supported by the state and local governments as well. And I'll put that in the chat for the group.
Thank you, Eli. And it looks like Namali has also put in a link in the chat for the CMS reopening guidance so that will help as well. Marianne, could you tee up the next question?
Certainly. The next question actually came to our team via email right before this training. And that question is, if there are one or more COVID positive residents in a facility, can they be served their meals on regular dishes, or must they be served on disposable dishes?
This is Eli again. I got volunteered for this one, and I would just say that disposable dishes carry their own risk of, allowing food to cool down, and there are foodborne illnesses that we have to be very concerned about. The CDC basically states that the likelihood of transmission is low just because COVID-19 doesn't survive for a long time on surfaces. So you would just want to make sure that your dishwasher, any cleaning agents are the effective dilution, you're hitting your temperatures, and you should be able to safely wash your reusable dishes and prevent those potential, foodborne illnesses from impacting your residents, because they are extremely prone to those as well. But Namali may have additional information if I didn't hit all the right points there. I must have. Thank you.
Hey, this is Namali. Sorry, I was on mute chatting away. I just wanted to say Eli's answer is exactly right, and we don't have guidance to change the way meals are prepared and served as a part of this, infection prevention response to COVID. I know a lot of centers have gone to using disposable plates, and in part that is maybe to keep anything that's coming onto a COVID designated unit from crossing back out. But with proper kitchen practices and sanitizing steps of dishwashing, there's no risk to reusable plates. Thanks.
Okay, this is Marianne again. I'm going to read out the second question that came in from the same nursing home via email. This one is also probably going to go to Eli and Namali, and that is, would using a barrier between gloves and a contaminated object be an acceptable practice when PPE is in short supply?
And that one, your glove should be your disposable item. You know, using an additional barrier is unnecessary, and we just have to make sure that we're using good standard precautions and good hand hygiene in these instances. I think that people can get too comfortable wearing a glove all the time, and if they're going from one contaminated surface to a resident care, we could definitely have a negative outcome there. So I would recommend, you know, if you have to touch that contaminated surface, you would, one, want to clean it so it's not contaminated for other people, and then dispose of your gloves and then perform hand hygiene afterwards. That would protect everyone as well as yourself.
Yeah, this is Namali. I completely agree with that. And I think we sometimes think if we add layers, we are making things more safe. But Eli's exactly right that often we stop doing some of the basic best practices like performing hand hygiene if we have a false sense of security that we're not contaminating our hands with those kinds of activities. Thanks.
Okay, thank you. Let me go ahead with the next question, which is on one of the slides. It mentions, and here are the words, provide alert, and then there was more text, document and care plan, and it was regarding sanitizing. Can you further explain?
This one's mine as well, and this was actually from the iPro slide. And my understanding is that if residents have a concern that their environment may not be clean, and if they would request to be able to have cleaning products to clean their areas, you would want to make sure, one, that that resident is, you know, alert and oriented, and that they could safely use those products. I would hesitate to allowing somebody to do that in a coupleted room, but this would be solely when you had a resident requesting to do that. Of course, we're not going to, you know, task our residents with that. It's when you have somebody that's engaged and concerned. And the care plan documentation really is to show, it's just to show that you took the steps to educate them about appropriate product use, you know, making sure they're washing their hands, all the things that go around with using that cleaning product.
Okay, thank you, Eli. The next question is, the test-based strategy is not effective because tests are not being returned in a timely manner. Right now, we are on day 10 since testing of employees with no results.
Hey, this is Namali. I completely agree with that comment that if you cannot get your test results within 1 to 2 days, your ability to comfortably act on those results definitely goes away. And I can understand the frustration that you're feeling trying to follow some of this guidance and not having capacity and access to timely resources to be successful. So I would encourage those of you that are experiencing long delays like that to make sure you're in touch with your local and state health departments, just so they're aware of the challenges that you're experiencing. Because if you're trying to respond to an outbreak and you don't have access to timely testing, there may be resources from the health department that could help. Thanks.
Thank you, Namali. And our next question is, if staff is needed to cohort in taking care of a resident, is it better for them to care for COVID-19 confirmed with COVID-19 recovered, or COVID-19 confirmed with resident on quarantine, new admits, and PUI?
Yeah, this is Namali, and I certainly want to hear from my colleagues who also presented on some of these topics like cohorting. If I'm understanding the question, and I may not be exactly right, the way I'm interpreting the question is if I have staff that I need to dedicate to my care of COVID positive residents, and I have some staff that are actually had previously been ill with COVID-19 and have now recovered. Is it better to have those COVID recovered staff working with the COVID-19 confirmed cases? And that is a good strategy, and one that facilities have employed even in crisis circumstances where they have staff that may have been exposed, or sometimes in serious severe staffing shortages. They may have staff who are known to be COVID infected but completely asymptomatic, and they have cohorted those staff to work with residents on a COVID dedicated unit. That is not a strategy, having infected staff work is not a strategy that I would recommend unless you are in severe staffing crisis. But if you have a group of staff who are recovered and you can dedicate them to care for your COVID positive residents, that is not a bad idea. And then, if they have to, if some staff are working with your COVID unknowns, people in observations or quarantine, I mean, remember, you're going to be using full PPE during the care of those residents, and most of our data suggest that when you're fully recovered in terms of your recovery and time from illness, there's a very low risk of shedding virus, especially in otherwise healthy caregivers. Thanks.
Okay, Lisa, do we have time for one more question?
I think one more.
Okay, I've got one queued up. Okay. Brenda says, I understand there's a new PPE video available that instructs the use of hand sanitizer use after each piece of PPE is removed. Is this additional step required?
Okay, my colleagues are being shy, so I'll take this. This is Namali. The incorporation of hand hygiene into your PPE removal process adds a layer of safety, right, to your doffing. When I talk to centers about doffing PPE and making sure their staff have access to hand hygiene, it's often because I'd like them to perform hand hygiene after they've doffed their gown and gloves, which are the pieces that come off first. And I don't want them to reach for anything on their face, like a face shield or goggles, until they've cleaned their hands. So I would, I think, say that you need to be able to perform hand hygiene as you're removing your equipment, in particular if you're going to handle any face protection. And I'm trying to think of a circumstance where you would doff gloves and then perform hand hygiene before trying to get out of a gown. And maybe the one circumstance I could think through is if you're using reusable, like cloth isolation gowns, that it would just, reduce the potential contamination of that gown as people are trying to get out of it after they've taken off their gloves, which are generally the dirtiest part of their uniform. So I think that would be a reason to incorporate that step before you, take the gown off. If you're disposing of the gown, then you probably could do the gown and gloves in one step and then do hand hygiene before touching anything on the face. Thanks.
And this is Eli Namali. I was just going to chime in and say we pretty well exclusively recommend the CDC doffing procedure because there's some great infographics which we can also put in the chat. And there's more than one way to doff, but I'm not familiar with the video. So whoever posed that question, if you could send that in, it would be great for us kind of to see what example they're using where they would want that done.
Thank you, Eli, and thank you, Namali. Next slide, please. And it looks like that's all the time we have for today. I would just want to say thank you for your participation in today's call. A special thanks to our speakers and also to our CDC colleagues and CMS colleagues for joining us during the Q&A portion of this event. We hope you found value in the topics discussed. And just as a reminder, please take a moment to complete our survey from today's event. You will be sent directly to the survey at the conclusion of the training presentation, and it also has been available in the Q&A box. Thank you again, and this concludes today's call.
Thank you for your participation. You may now disconnect.